Hello, everyone. My name is student Dr. Jake Schneider. I'm a third-year medical student at Kansas City University, and I am going to present to you guys today an article that I found online, Uterine Transplantation, a Maternal-Fetal Medicine Perspective. I am particularly interested in OB-GYN, so this article in particular was of interest to me. So why would someone want to have a uterine transplant? So the main reason why this is um, necessary for some women is because women want to carry their own baby, and some of these women who want to carry their own baby are unable to conceive or carry one on their own. So good candidates for a uterine transplant is women with absolute uterine factor infertility. So the only women who have infertility or experience infertility that would qualify for a uterine transplant would be because the infertility that she's experiencing is solely caused by a lack of uterus or a non-functional uterus. And that could be either congenital or acquired. So congenital, Meyer-Rokitansky-Kuster-Hauser syndrome was the main one that was discussed in this article. And that's when the patient or woman would be born without a uterus. And then acquired women who have had hysterectomies in the past for various reasons, including fibroids or obstetric hemorrhage. And obstetric hemorrhage is interesting in particular because for that to occur, many of these women who may have had a hysterectomy due to obstetric hemorrhage already have children or a child, but want to have another. So the uterine transplant would allow them to do that. So again, some people might ask a few questions. Why not other options to have a child? Because if the goal was to just become a parent, adoption would satisfy this goal and be an easy option. And if the goal was to have a genetic connection to the child, then surrogacy can also achieve that goal. But adoption and surrogacy also do have their limitations because they are very expensive and they can be very long processes to have to go through for parents. And adoption and surrogacy are preferred by many women, but there are some women who definitely would rather have their own child. And surrogacy also is illegal in many of the European countries, including Germany, France, Italy, Spain, and Portugal. So that's another limitation that patients might have in those countries. So again, why have a uterine transplant? Many women want to have the ability to bear a child for various reasons, and that could be personal reasons, reasons, or political reasons. But these women want to be able to conceive, grow, carry, and birth a child. So this was like a little chart that I found really like a great way to kind of explain the ways to have a baby. This was included in the article that I saw, and I really wanted to explain this to all of you just to make it very clear. And I think this is a great way to do that. So each of these circles kind of contain ways to have a baby: parenting, genetic connection, and then gestating or carrying the child. So again, parenting, adopting a child would satisfy. If you wanted to be a parent, you can adopt a child. If you wanted to have a genetic connection to offspring, but you didn't want a parent and you didn't want to carry, then you could have donate sperm or donate egg, and that would satisfy you having a genetic connection. And then gestating or carrying a baby, if you wanted to just do that, then you can opt to just become a surrogate. But the traditional parenting method is a combination of all three of these things. And for people who aren't able to do that, the uterine transplant may be able to satisfy that wanting to be able to have all these three things, especially in women who don't have a uterus or one that's functioning. So this slide is actually separate from the article. I just wanted to learn a little bit more about what a uterine transplant is, what that process is like for these women. So I found some information on the University of Alabama, and there was actually more, some other academic institutions like Johns Hopkins and UPenn that also had some information about the process that that consists of having to go through a uterus transplant. So this is a 2 to 5 year process that consists of 5 phases. The first one that's not really considered a phase is the medical evaluation. So there are requirements that patients need to meet in order to be able to qualify for a uterus transplant. Just a few to name would be they can't have diabetes or chronic kidney disease, and they also need to be normal weight. And there's also a long list of different criteria that they would have to meet. But once that criteria is met, we can start with phase 1, embryo generation via IVF. So given the fertility medications, patients are given fertility medications to reduce eggs, which are then removed and fertilized outside of her body, which are then frozen. So that's the first step. And then after that's done, the second step is transplantation. So this would be transplantation of the uterus. So the uterus is removed from a donor and surgically placed into the recipient, which at this point, the recipient will also start immunosuppressive medications to prevent rejection of the uterus. Then once that is started, typically there's a period of time that you would need to wait to start embryo transfer. I saw online at a few places that it was about 6 months. But at this point, after 6 months, you'd be able to take frozen embryos, thaw them, and then place them into the uterus. And keep in mind that during this pregnancy, the immunosuppressive medications do need to be continued throughout the entirety of pregnancy. And I'll talk a little bit more about that later in the presentation. And then the next phase is delivery. So all of these uterine transplant pregnancies are delivered through a planned C-section. Most of these patients are going to have 1 to 2 pregnancies with the transplanted uterus. And then after they're done wanting any more children, the uterus is removed, which at that point, the immunosuppressive medications can be stopped. So biggest concerns for uterine transplantation. So pretty much in the article that I was reading, there was 2 questions that a lot of patients have. The first one being, will uterine transplantation result in a successful pregnancy? Because that's the whole point. We want to make sure that the patient who is having the transplanted uterus, that they can have a successful pregnancy, because that's why they want the uterus in the first place. And then the second question is, will uterine transplant result in a safe pregnancy for the mother and baby? And I'm going to talk a little bit more about the risks for the mother and the fetus in a little bit. But to answer both of these questions, we must provide women with reliable data to answer these questions. And that's why long-term research studies is so important in this a field of study. So as of right now, there is a lack of research. This article was published in 2022. But so one of the systematic reviews that he used while doing his creating his article, Daly et al. Completed a systematic review in 2020 of over 50 uterine transplants. Of those transplants, there were 16 live births. So 16 live births is really not a lot. That is very limited data, but the data is promising. So what's nice about this early research is that it can give us confidence in that we're moving in the right direction and making these uterus transplants possible for women. But again, will that data be able to, will you be able to use that data, across the entire country, across the entire world? That's still being researched. So what do physicians need to consider to make sure that pregnancy after undergoing uterine transplant is safe? So I'm going to talk a little bit about maternal risks and fetal risks. We'll start with the fetal risks. So first, the immunosuppressive treatment and the teratogenicity of these drugs. So women who undergo a uterine transplant are required to be on immunosuppressive medications throughout the entire time that they have the uterus. What is interesting is that these immunosuppressive medications can actually be stopped after the uterus is removed, which is interesting just because, most transplants are for life-saving organs, where those organs are going to be with the patient for the rest of their lives. So it requires them to take the immunosuppressive medications for life, whereas this is not the case. But the immunosuppressive medications will be used during pregnancy. So one of the biggest concerns that people have is, will these immunosuppressive medications cause harm to the fetus? And immunosuppressive medications have been studied extensively during pregnancy, and tacrolimus and azathioprine do not seem to be teratogenic, and those are two medications that would be used in a uterine transplant. And what is important to note is that these immunosuppressive medications are the same medications that would be used that have been studied in pregnancy, and there really is no difference between a natural pregnancy on these immunosuppressive medications and the uterine transplant recipients. So the immunosuppressive drug regimen given to a uterine transplant recipient is not considered risky. Next is prematurity. So another concern is, will the baby be delivered to term? So Dalio et al. Once again also found that neonates born after uterine transplantation had a gestational age of 31 to 37 weeks. Most of those were born were late preterm, so 34 to 36 weeks and 6 days, so right before 37 weeks. So the risk of prematurity that were listed, underdeveloped lungs, asthma, intellectual disability, and obviously that is a concern, especially if there is a possibility that a person who is going to have a uterus transplant, that they may deliver prematurely. But the risk of prematurity in a patient with a uterine transplant is no different than the risk of prematurity in a patient who will have a challenging pregnancy or a high-risk pregnancy. So for example, multiple gestations, so like a triplet like myself, the risks that are associated with prematurity in that pregnancy is the same risks for a patient who has had a uterine transplant, who is likely to also deliver premature. And finally, the last fetal risk that I'm going to discuss is growth restriction. So the concern is that, will there be adequate blood flow to the uterus to provide enough blood flow to the placenta to provide enough blood flow to the fetus? So blood flow to the uterus may be weaker and lead to placental insufficiency. So Jones et al. Published a study in 2019 reviewing 45 uterine transplant cases that included 9 live births. He concluded that the risk of intrauterine growth restriction does not seem to be worrisome from early data. Again, this is only 9 live births, so the data is very limited, but again, it is promising that growth restriction is not going to be a significant worry for patients who do undergo a uterine transplant to become pregnant. So next I'm going to talk about maternal risks. I'm going to start with surgeries. So the surgeries required for a woman to undergo a uterine transplant are listed here. And because there's more than one surgery that is involved in this entire process. And like I mentioned earlier, typically this process is 2 to 5 years for most women. That is a lot of surgery for such a short period of time. So, you start with the uterine transplant, and then after you become pregnant, they're all delivered through C-section, and that could be 1 or 2 typically, and then hysterectomy to remove the transplanted uterus. So that in total could be 3 to 4 surgeries in 2 to 5 years, which is a lot of surgery for someone. So the risk of surgery have to be discussed with the mother, including infection, bleeding, and etc. But that's something to consider. Is the mother going to be able to handle all these surgeries? And then 2 other maternal risks are immunosuppressants. So again, these patients are required to be on immunosuppressive therapy throughout their entire pregnancy and throughout the entire time that they have the transplanted uterus. So again, that can increase the risk of infectious disease. So that's something that needs to be discussed, as well as preeclampsia. And it has been studied that there is an associated risk or increased risk for preeclampsia in patients who have had uterine transplants. So preeclampsia definitely needs to be discussed at length with these patients as well. And although there are some clear morbidities associated with uterine transplantation, the data does show that there are generally good outcomes for patients. Long-term data is still required at this time. I'm going to talk a little bit more about that in just a bit. But the short-term data, the pregnancy itself and then the delivery of those infants or neonates has been pretty good overall. So how do physicians ensure that women who choose to undergo a uterine transplant have a full understanding of this process? So I'm going to talk a little bit about the informed consent process. So informed consent, a woman and their partner need to have a clear understanding of what the physicians know and don't know. So it's vital that as maternal-fetal medicine physicians, they discuss, we don't know the long-term outcomes of a uterine transplant and the pregnancies that these patients have experienced with patients who are considering this as an option. Outcomes for the pregnant woman and her neonate after uterine transplantation need to be discussed. That includes short-term as well. And obviously, because we do know those outcomes, we can discuss that with the patient. And again, have to be honest with them about how there is limited data. We also have to discuss the risk associated with pregnancy for the mother and neonate, and then that I just discussed, and then also just safety concerns. So when can a uterine transplant move from an IRB-approved research study to standard therapy? So this article was published in 2022, and at that time, I believe that the only uterine transplants that were occurring for pregnancy were being done through research studies. But as I was doing research and I was looking at University of Alabama and UPenn and Johns Hopkins, it looks like there's a lot of information online now for patients who are interested in this as a option to become pregnant. So I'm not 100% sure, but I'm thinking that it's moving out of the research realm and moving into an actual option for patients moving forward. So current research as of 2022, there is a lack of long-term outcomes. Long-term outcomes on the babies born after uterine transplantation. We don't know significant medical outcomes or health outcomes of these babies, especially because the oldest child from the surgery is now 8 or 9. So we don't know the effect that this might have on them, if there is any, into their teens, 20s, 30s, 40s, 50s, and as they continue to grow. And then other concerns that we don't know enough about yet is because of the low number of total pregnancies that have actually occurred through a uterus transplant. And then rare adverse pregnancy outcomes are likely to occur. It's just like with anything, they are expected. But again, we haven't seen any of that yet. So we can't discuss that with patients because we don't know that they're going to exist as of right now. And then also, we don't know if there's going to be any acquired abnormalities. Because they're all IVF pregnancies, these patients are usually screened for genetic aneuploidies like trisomies, but there's no research on acquired abnormalities like fetal infections or fetal demise. And then finally, anatomy changes in these patients because they do have surgeries, and strictures are likely to form post-surgery. It might make it difficult for doing, for example, like a cervical cerclage if that's needed at the time due to a transplanted cervix for the patient. So there's just some procedures or steps that are involved in the process of having a uterine transplant through pregnancy that are just not 100% clear yet because of the research that is still ongoing, but is not sufficient at this point. And then the conclusions, uterine transplantation is an innovative therapy for women who experience uterine factor infertility. As this form of treatment moves from research into standard care, ongoing vigilance and care is necessary to protect women and their neonates. And informed consent is extremely vital prior to starting this process for patients. And then there's my references. And that is it.